Okay, I think we can go ahead and get started then. We have 78 attendees. So welcome everyone. I'll hand it over to Annalise as the moderator in just a second. But my name is Lindsay Bonanno. I'm a health science specialist with our capacity building and partnerships branch in USAID's Office of HIV/AIDS, working on our local partner transition. So really excited for this session. I think we've had a great meeting so far. Just a few key housekeeping issues. When you are, we welcome everybody to include their questions in the chat box. When you're submitting your questions, please change the drop-down menu where it says all panelists, change it to all panelists and attendees. So everyone is able to see your question. Adeline, it looks like, I'm not sure if you have joined as a panelist. You might have joined as an attendee, so we'll have to get that resolved. So just 1 second, and then I'll work on that. So yes, so if everyone can please make sure you send your questions to all panelists and attendees. For panelists, we're asking for you all to please put your video on if possible, as bandwidth allows. And we'll be very much keeping to time. So we'll be very polite, but if our sessions are going getting long, we will need to cut people off because we do have a pretty strict time frame. We do have translation available, so please use the interpretation box on the bottom of the Zoom link. So with that, Annalise, I'll turn it over to you.
Great, thank you so much, Lindsay, and thank you everyone for joining our dream sessions today. My name is Annalise Lim, and I'm a Senior Youth Advisor in the Office of HIV/AIDS here at USAID headquarters. And I also have the privilege of coordinating the USAID Dreams portfolio across 16 countries. So I have the pleasure of working with an incredible team that cuts across several branches and divisions here at the Office of HIV/AIDS. And just a couple of quick notes, because I know some of you may or may not be Dreams countries. And I'm really happy that you've been able to join today. Many of you probably know that Dreams is a comprehensive prevention package for adolescent girls and young women, 10 to 24 years old. And we're currently implementing in 15 countries, and South Sudan will begin implementing in the next COP year. And we're really happy to see these presentations from our local partners, not only to highlight their great work, but because Dreams is really scaling in COP20. We have grown from a global budget of about 190 million to a global budget of almost 400 million for the upcoming implementing year. So Dreams has 4 core components: to empower adolescent girls and young women and reduce their risk to HIV, to strengthen the families of adolescent girls and young women, to mobilize communities for change, and to reduce the risk of sex partners of AGYW. And you'll notice as we go through the presentations that every country then develops their primary and secondary core packages of services that fall within these 4 components. And you'll hear quite a bit about those from our partners today. As a reminder, while many of you may not be a Dreams country, you are all hopefully programming for prevention for adolescent girls and young women. And of course, we're happy to share any of these Dreams resources with you. So today we have 3 presenters. And our first one will be Sylvia Mulili. Sylvia is the head of programs for African Evangelistic Enterprise in Rwanda. Our next presenter will be Bernadette Harasis. And Bernadette is the chief of party for the Dreams Project with Project Hope Namibia. And then our third and final presenter today will be Adeline Menekuzwe, who is the monitoring and evaluation manager for FXB Rwanda and serves as the technical team leader for the USAID Turengere Abana program. So our first presenter today is Sylvia, and so I will turn the floor over to her and go off screen for now. Thank you.
Thank you so much, Adeline. As mentioned, my name is Sylvia, and I'm happy to be with all of you. Good morning, good afternoon, wherever you are. Annalise, is the presentation ready?
Yes, you should just say next slide and we'll be able to drive from here.
Thank you. Next slide.
FPD, are we able to drive the slides, please?
I can't seem to see the slides. I'm not sure what's going on.
I think the team is working on it right now, Sylvia.
Sure, thanks.
We see the slide, but I don't know if we can there. Oh, now we don't see the slides.
Great, thanks. So welcome again. My name is Sylvia. I work with African Evangelistic Enterprise in Rwanda as the head of programs, where I support the DREAMS program. So in our presentation this afternoon, or this morning, wherever you are, we're going to be looking at the role of the changing role of government and private sector in humanitarian development. And we're going to highlight the importance of multi-stakeholder collaboration in driving program adaptations and improving service delivery. So that's a quick overview of what we're going to discuss. Next slide, please. So as a brief overview of DREAMS, DREAMS was introduced in AEE Rwanda in 2018, and it was introduced to complement the work done through the existing OVC program. And it was in response to a large number of children and adolescents identified as being at risk of exposure to HIV. These were mainly identified as children living with HIV positive caregivers, children who had experienced violence, especially sexual violence, children of female sex workers, and those children who are living in extreme poverty and predisposed to transactional sex. At the time when DREAMS was being introduced in Rwanda, there was a relatively stable HIV prevalence across the country. However, in Kigali city, the urban areas, the HIV prevalence at the time was about 6%, which was quite high. And so we began operating in one of the districts in Kigali called Gasabo. And this was also in response to the high rate of sexual abuse among girls, which at the time was about 12% for girls aged 13 to 17 and 65% for girls aged 18 to 24. In terms of our reach or scope of work, we have reached 6,151 adolescent girls and young women and 431 male partners. And many of our stakeholders are divided into public, private, and community-based. Next slide, please. So this really shows our performance against the DREAMS program completion continuum. And as you can see, in terms of completion of the full primary package, we are at par with the number of AGY enrolled into the program, but we seem to see variations with AGY accessing the secondary services, especially among the 20 to 24 age band, where there is a low access or completion of the secondary services. And also the graduation from the completion of the program, we also can see that we have very few AGY who have transitioned out of the program to date. Next slide, please. Next slide, please. So this is a brief overview of infectious diseases. As we all know, the trend of infectious diseases has been going up. For the last 30 years, we've had about 12,000 outbreaks, which range from global pandemics to regional or local outbreaks. And in Africa alone this year, we've noted about 12 outbreaks, 9 of them being in East and Central Africa, where our programs are. In terms of contagion of the disease, it has been established that within under 36 hours, a disease is able to spread from a remote village, say in Rwanda, anywhere in Rwanda, and reach any major city in the world. And so we can see that infectious diseases are becoming, having a more, leaving behind a trail of devastation and having a larger impact than has been in the past. But more significantly, what we notice about infectious diseases lately is that there's decreased ability of the communities to cope up with the frequency of the outbreaks, as evidenced with our program that we've been implementing. Specifically for the DREAMS project, we see that there's been a delay in access to services, whether it is in terms of HIV testing, whether it is in terms of accessing training and any other services. There's been that delay. And significantly, this has led to increase in SGBV cases in certain areas. And in our project, we've recorded about 132 cases. But what is profound for us is the increased economic vulnerability that comes out of these diseases affecting the beneficiaries that we work with. So if we're speaking about dealing with risk, and then at the same time, there are factors that are expounding that risk, you see, we seem to have a contradicting trend there. Next slide, please. So next, so this table gives us an overview of how our program has adapted in the different phases of COVID. And in the first phase, it was really a period of lack of awareness, which was January to March. From March to mid-May, this was a period of, as you may be aware, where Rwanda entered into a lockdown. And during that period of the lockdown, one of the measures we put in place was using remote management. And we relied a lot on virtual case management, where we used telephone support, both to the caseworkers and also to the beneficiaries, where the caseworkers would get in touch with the beneficiaries. We also relied a lot on the caseworkers being able to conduct some home visits where possible within their area of jurisdiction, because movements were allowed within the small areas. And during those home visits, there was a lot of emphasis laid on COVID messaging and a lot of emphasis on the use of telelearning. And what the biggest adaptation during this period was the use of dead drop method to distribute condoms, where caseworkers would contact the beneficiaries and agree on where to drop off the condoms and wrap them up in a way that they are concealed, and therefore in that way we were able to access the AGY. In the third phase, which was from mid-May to September, there was a bit of resumption of normal activities. Some of them are highlighted there, a little bit of remote management. But there are two main adaptations around this period, which involved the community-based HIV testing, where health facility workers would come to the safe spaces and be able to provide testing services to the AGY, but also the use of mobile TVET, where the vocational trainings will be done within the communities. And this is the focus of today's presentation, looking at one of these adaptations, which is taking the services to the AGY in the communities. Next, please. Next, please. Thank you. Next slide, please. Thank you. So for us, this slide really is next. I think this is a really familiar scene to most of us, where we find, whether they be empty classrooms, empty training centers, empty safe spaces. During the lockdown, many of us experienced this. And for us, this signified barriers to accessing vital prevention services for the AGY. For us, with regard, why we consider TVET as a major prevention service, this is because of, next please, next. TVET are useful in providing knowledge and skills to the girls. And after enrollment, when they enroll, usually most of these girls are school dropouts. And so they have no skill and they have no hope to go back to formal education. And so they have no means of being able to get employment. And therefore, when they come and enroll to the TVET, they are able to get vocational skills, whether it is in hairdressing, tailoring, metalwork, and so forth. And from this skill, next please, the TVET, next please. Next please, sorry. The TVET institutions give them certification, and in Rwanda context, they get a recognized certificate from the Workforce Development Authority. And using that certificate, we've seen that those certificates have been very instrumental in allowing the girls to get employment in different places, and also to be able to start their own businesses. Next, please. And once they access employment, we have seen that these girls are now able to have their own income, and with their own income, they are able to meet their own needs and be less dependent on whether it's the male sex partners or other people to provide for their needs. And this is why we find TVET being instrumental in prevention of HIV/AIDS. Next, please. Next slide. So the big question is how did we manage to get these services to the AGY? Early on, during the lockdown, from the regular messaging from the government, it was clear to us that there was a high probability of 2020 becoming a dead academic year, which meant that formal education and access to institution-based learning was not going to happen. And so we were faced with the challenge of figuring out how we could access, how we could increase access to training to the AGY. And while we brainstormed as a program on what we would do, we came up with the idea of extending the services and reaching the AGY where they were, which was going to be a little bit easy given the restrictions in movement. However, while we thought about this, we immediately faced three main challenges. And the first one was, were the institutions that we worked with going to be able to accept to offer mobile services? The second challenge we were experiencing was whether the institutions would be willing to make changes to the curriculum to accommodate the mobile training. And the third is, how are we going to convince the government to grant us access to conduct training when institution-based learning was put on hold? We clearly discovered that as a program, these were challenges that we could not face, but we could not solve by ourselves. And so one of the things we did during this period was convene meetings with the different service providers, that is the TVET institutions, and also representatives of local government, to be able to just brainstorm and figure out how we would be able to tweak or to adapt our interventions in a way that would both satisfy the requirements by government on safety and hygiene, and also ensure that we don't spread the COVID, but at the same time be able to reach the AGY. So for us as a program, the key takeaway we got out of this was we had a dilemma that we could not be able to solve, but through a series of meetings with the different stakeholders, they were able to provide input on how to change our strategy. So the change of strategy in terms of providing shorter courses, shorter durations to the course, and in terms of including a business component into the training facility, were ideas that came from both the government and the TVET during the brainstorming sessions. And for us, we thought that this was a game changer for us. So what we did was we were able to identify 5 sites where we would establish the temporary learning sites. And in those sites, they were more or less a business, a specific, if say we were providing training on tailoring, we would open up a tailoring shop, which would serve both as a learning site and at the same time be able to be a site where the girls received training. And then we limited the training sessions to about 2 to 3 hours to ensure that they were able to serve clients on a walk-in basis, but also be able to get learning. And for us, we felt that that close collaboration was very, very instrumental for us in being able to advance access to this service to the AGY. Next slide, please.
Hi, Sylvia. Sorry to jump in, but we've surpassed our 10 minutes. So if you could just wrap up these last 2 slides. Thank you.
Sure. So in the 2 slides, just click next, please. Click next, please. Enter so that I could sum up. Thank you. Okay, so on this slide, we wanted to show the difference in terms of achievement between the institution-based TVET and the mobile TVET. If you could enter, we could see the graph. And we realized that one of the key takeaways from this slide was that the teen mothers were not accessing the institution-based TVET. But when we started to roll out the mobile TVETs, we saw a very sharp increase in enrollment of the teen mothers in the mobile TVETs. And though there's not been any graduation happening for the mobile TVETs yet, because we started in August, we've actually noticed the difference between how the subpopulations are engaging with the 2 different learning sites. And as we go forward, we'll probably take this into consideration. I think I'll end there because the last slide is just to show how the mobile TVET looks like and to show what were the enablers which I've already discussed before. Thank you very much.
Great. Thank you very much, Sylvia. And my apologies for having to jump in. I always hate to do that. We will move on to our next presenter, who is Bernadette. And as a reminder, please make sure that you add any questions to the chat box so that we can discuss them after our last presentation. And Bernadette, if you're able to turn your video on, that will be great. And if not, that's okay as well. Thank you.
Thank you, Annalise. Also for the introduction. As you said, my name is Bernadette Arases. I'm the Chief of Party for the Dreams Project with Project Hope Namibia. And I'm happy to be on this panel to talk about improving services to empower Dreams participants. And our specific focus is on how did we maintain contact with and deliver services to adolescent girls and young women during COVID pandemic. This is not my presentation.
PD, if you could please go back. The Bernadette's presentation was the next in the deck. So if you could just go back several slides, thank you. We're just getting a preview backwards of your slides, Bernadette. Great, thank you.
It's fine. Yeah, I think we can, yeah, this is where it starts. No, go back to the other one. This is my presentation. It's just a picture of our girls before COVID. This is not mine. Go to the next one. Yeah, I was just saying, let me start with the background, and I think Annalise and Sylvia has alluded to it as to what the goal of DREAMS is all about, so I will not spend time on that. Just to say it's a USAID funded, PEPFAR USAID funded project. It's a 5-year project that started in June 2018 and will end June 2023. We operate in 5 districts, as you can see on the map. We are in the north and northeastern part of Namibia, as well as in central part that happens to be the capital city of Namibia, Windhoek. Others all alluded to it, that DREAMS is a complex project, and we work with a consortium, Project of Namibia being the prime recipient of the grant, and we work with 5 other sub-grantees, which is Star for Life, IntraHealth International, Lifeline Childline, the Namibia University of Science and Technology, and Project of US. If you can go to the next slide, please. I think it's critical to note that, as I said earlier, DREAMS is complex, and it is multi-layered, it's age-appropriate, it is also an evidence-based program, and we see that there are different levels. The primary interventions are core for the girls, and it's basically compulsory to participate in all these primary interventions, while the secondary interventions look at the needs of the particular needs of an adolescent girl and young woman. Next slide. So why did we adopt our program? As we all know, COVID came, and it happens to all of us. Our president declared a state of emergency on the 17th of March this year, and 10 days later, there was national lockdown. And if we look back to 29th September, the data that we can report is Namibia reported 1,140 COVID positive cases, and you look at our population size, we just 2.5 million in the country. And if you see the map, you can also tell from the map that community transmission happened, and we have 99% of our cases came through community transmission, and 1% was imported. Also, the cohort that we work with is impacted because 73% of the cases are amongst this age group 20 to 49. We also reported at the 29th September, we reported 121 deaths, and we see health workers were also the group that was affected. So next slide, please. So in terms of our response then to mitigate the impact of COVID on the adolescent girl and young one, Sylvia previously alluded to the delay in service provision and all the effects on the girl. And we had to think what to do so that we maintain contact with the girls, we continue to offer services to the girls, and also make sure they receive the life-saving information on COVID prevention, and also making sure they receive continuous sort of information around DREAMS curriculum. We developed a system, a virtual assessment tool. 2 tools basically, one for the caregivers of 10 to 14-year-olds, and the second tool for 15 to 24-year-olds that is administered directly to them. Our mentors received training on the tools, how to administer the tools, and they were also given adequate airtime or data to make sure they're able to connect to the girls. Also critical to this was to make sure we ensure confidentiality and also the safety of the girl. The mentors stay in contact with the girls, and they at least call the girls twice a month to make sure all these things are done. The contact is maintained. We know what the needs of the girls are, and also what services they need and what needs to be, and where to take the services, as well as ensure they receive information. Additional to this, the assessment tools, we also develop a database to enter the assessment data on the database, as well as a dashboard, to make sure we are able to monitor the performance of the field workers when they render the services to the girls. Next slide, please. So our approach, you see the diagram there, our data is entered into the database, our RedGap database. And as you can see from the diagram, there is a little person doing the virtual assessment and entering the data. The data goes on the cloud, and automated email messages or even SMSs are sent to Dream staff to make sure it could be a nurse, a social worker, or even our mentors to make sure we attend to critical health and safety needs of the adolescent girls and young women. Also, the girls were able to tell us, or still able to tell us, where they want to receive the services, whether it has to continue virtually or whether they are able to access a youth-friendly room at the health facility or any convenient place to them in the community, close to their house, wherever they indicate in household, or either through household visits to a particular girl. Thank you. Next slide. So this is the heart of our assessment. How did we provide services? At the end of April, we had 22,655 girls in our adults and girls and young women in our cohort. And only 60% of them had documented contact numbers. The rest didn't have numbers where we could contact them. We also were able to call 13,073 girls. We could reach them with the calls, and 85% of them received the virtual assessments. The 11,073 received virtual assessments. And out of that, you can see what was reported to us is GBV cases, sexual violence. We received 52 cases of sexual violence. 136 physical or emotional violence. The girls also indicated a need for overdue referrals or initiation onto treatment, so 190 of them indicated that. And also what we also picked up from the dashboard is that there was severe hunger. 1,176 indicated the need for support. In terms of the cases, GBV cases that were reported, 50 of the 52 that reported sexual violence received post-GBV care, and 103 received emotional, physical and emotional, reported, sorry, let me retract. 136 who reported physical violence, out of those 103 received services. From those who indicated need for medical referrals, 60 were initiated on PrEP. These were new cases. PrEP referral, we had 82 cases that needed PrEP referral. Restarting on PrEP, so after the interaction with the mentor, they were actually motivated to restart again, and 33 were restarted on PrEP. And we had 76 that required ART refill. Out of the 1,176, only 309 were able to receive provisional short-term emergency support. Oh, sorry, not provisional, but received short-term emergency support. You will ask me why such a small number, but the process of validation takes time. And also some of them were not eligible for the short-term support. They could be redirected to other services. And also the issue of lack of national documents came out strongly there. Below is a block that also indicate the additional services that we provided to adolescent girls and young women. Through this approach, we were able to increase condom uptake. We actually delivered condoms to 1,298 girls, sanitary pads to 4,415, IC materials to 8,830, basically double, because we deliver the sanitary pads and condoms in a box that we call a comfort pack. So we had double information, IC materials in the box. In terms of WASH education, we reached 7,360. School materials were delivered to 802 girls who wanted to, who needed the service. Can you please go to the next slide? This is just an image of the main page of our
Hi,
dashboard.
Bernadette. Sorry, just to say we'll need to wrap up in 2 minutes. Thank you.
Okay, I'll be done. This is just to show you what I reported. This is how our dashboard look like. You can go to the next one. This is just a map. You know, our dashboard is interactive. If you look at this map, it can tell you exactly what services, the facilities that rendered services to adolescent girls and young women. So if you would click on a district, it can show you who received PrEP, who received other OVC services, or whatever you want to know. From the map, you can get it. You will also see that during COVID, people went out of our districts where we operate, and therefore we have probably the 9,000 that we could not reach. Next slide, please. This is just pictures of what happened during COVID, that we had girls that received economic strengthening opportunities. They started their own sewing project. They had startup kits to buy their own sewing machines. And it was, we had public-private partnership and government engagement as well. The one on your right is comfort pack that we, with condoms, sanitary pads, and information material. Next slide, please. Just the lessons that we have learned. We know that it works to use the phone to stay connected to the girls. It's a feasible strategy that we want to continue employing. Also, a recommendation that we realized, the future is virtual, so we need to ensure we update our contact information regularly. We also will have to leverage public-private partnership support so that girls can access telephones. And we want to migrate or introduce electronic virtual assessment tool. Currently, it's paper tools that we're using. And then maybe last to say, for those who didn't have access to phones, we were able to reach them in person. Thank you very much.
Thank you very much, Bernadette. I'll now turn it over to our final presenter, Adeline. And if you are able to turn your video on, that would be great. And if not, no worries. So over to Adeline. Thank you.
So, good afternoon. My name is Adeline Mankuzwe. I work for FXB. FXB is a local non-governmental organization that implements USAID-funded Turengera Abana program with DREAMS interventions in Rwanda. Next slide, please. So today we want to give you a brief on the DREAMS implementation under this program. So we are targeting 3 districts in Rwanda, and the districts are selected based on the epidemic control, based on HIV prevalence rate, based on GBV rates in those areas. And this year we are supporting about 5,600 adolescent girls and young women, and we are targeting to have them to increase the number of targeted adolescent girls and young women in this coming COP, or this new COP. We started it a few days ago. So since the start of implementation of these DREAMS in Rwanda under this USAID Turengera Abana program, we have reached many adolescent girls and young women, but about 2,500 have completed the interventions and a program that have been served during this past period. Next slide, please. So as you may know, this DREAMS program, based on the experience we have had in Rwanda, it is really needed in the community to support adolescent girls and young women, mostly who are at the risk of getting HIV. But to prioritize the most in need, we have set together the selection guidelines that we base on while selecting beneficiaries for these DREAMS interventions. But many of them we focus on adolescent girls and young women who never attended school, those dropped out from school, those GBV survivors, teen mothers, female sex workers, and others who are at the high risk of getting HIV. Next, please. So this is a picture that shows the achievement that we've had with this DREAMS program. We have achieved to give the services to these girls, and they are being served according to their age band and to their segment, so that we are able to focus and give the service based on the needs of each adolescent girls and young women. Next. So quickly to give you an overview of how the program is empowering adolescent girls and young women in Rwanda. So we are focusing on various interventions, but mainly we are targeting these girls with GBV preventions and life skills, social asset building, where we bring them to a safe space. We have trained mentors that are serving, supporting those adolescent girls and young women. And when they meet in their safe space, girls are comfortable and they can exchange their life together with their mentors, so as the program is able to really respond to their needs. So also they are getting sexual reproductive health education through those safe spaces, and HIV prevention and HTS, of course, to help them to prevent HIV. We get them to be tested for HIV and support those in need according to the result from HTS. So also we are focusing on education support, where we provide education to adolescent girls and young women, mostly the younger girls from 10-14 and 15-19. And we are supporting them to attend primary and secondary school. And from this service, we are giving them materials, school uniform, and most importantly, with school monitoring and following up with their education to ensure they are attending their schools, they are performing well, so as they are really empowered, as we are ambition to have them empowered. So we have supported about 4,600 adolescent girls with education, but not only education service, we are also providing economic strengthening services to them through vocational trainings, through apprenticeship and saving groups, to make sure they are empowered and they are able to economically be sustained and cover their basic needs, so as to protect them from any risk they may have with this. Next slide. So this part of the intervention we are providing for school retention, as I was describing. So this is a mentor providing, on this picture you see a mentor providing school material to a young adolescent girl. And part of the support, we are giving scholastic materials, uniforms, school fees, feeding, and importantly, school performance monitoring, because we believe that we can't give only this support without following and make sure those adolescent girls are really performing well for their better future. As a result from this close collaboration between beneficiaries, mentors, program staff, the school attendance and progression of these adolescent girls and young women has increased from 60% to 92% from 2018. Next. Another component or other services we are providing to these adolescent girls and young women is economic strengthening. So with economic strengthening, we collaborate with TVET schools to make sure those girls are attending certified vocational training schools in Rwanda. And we provide them tuition fees, the internship and work readiness services. And at the end of their training, the program provides startup kits, so as we ensure that those girls are, have access to employment and they are able to sustain the program activities even if they even after the completion of their program. And also we collaborate with those girls and other local institutions for market assessment and linkage, so that we ensure we provide the training to this girl, but then after she is able to get the employment. And from our past, 98% of those supported and completed the interventions are currently having employment, where the employment they created on their own or being employed by other employers. Next. Next slide, please. Next, okay, so for our saving group, what the program is doing is to make sure each girl is being served in any way. So those who can attend education, the formal education, they are supported to attend the school. Those who can't attend this formal education school, we support them to go to the vocational trainings, but also we have other category of the young women who are attending saving groups. And those saving group, this saving group is a key intervention that is provided to reduce the vulnerability among these adolescent girls and young women and their families. And through their saving group, we also bring in their parents, the parents of younger adolescent girls and young women, to also join saving groups, so that we target those adolescent girls and young women, but also their families. So the targets or the targeted beneficiaries to join these saving groups, they are the adolescent girls above 18, and also the parents of 10 to 17 adolescent girls and young women. From these savings, we have noticed that their saving has increased from $1 to $5 per week since 2018. This saving is helping those girls and their families to cover their basic needs and be able to sustain in their community. Next. Next, please. So as said, so these girls are being served at a safe space. This is the center where they are receiving the safe spaces. We collaborate with communities and make sure we find the very confidential and comfortable safe spaces in the community, whether some churches are providing safe space, schools, community sector and sales offices, youth centers. We have some safe spaces at health facilities. So what we do is to set a convenient time and schedule with adolescent girls and young women and the time where they will be comfortable, and we have this safe space, really safe and free to accommodate these girls. Next. So these girls are being supported by mentors, and mentors in a few is someone who is a role model in the community. It is selected by, she is selected by adolescent girls and young women themselves, and they have to be at the age of 18 to 35 to be able to interact with adolescent girls and young women. They have a high school minimum as education and a good character and commitment to support and serve these adolescent girls and young women. Next. So to ensure that these adolescent girls and young women are receiving the quality of services, the program ensures that these mentors are well equipped and trained. So the program has recruited and trained 80 mentors in the respective safe spaces, and these mentors are provided with various trainings, but the key ones they have received is HIV/DVT prevention, stigma and discrimination, HTA services, life skills, linkages, and reporting, among others. Next. So this program is not only focusing on adolescent girls and young women, but it also looks on their surroundings, their families, their community. So in terms of supporting their families, we are implementing a Family Matter program, which is an evidence-based curriculum that we are using for positive parenting, for a great communication between parents and adolescents, And it is based on the experience, this curriculum has opened those parents to interact with their children. And this is a great approach that is supporting even the program to reach their goals, as those girls are receiving knowledge and skills from their mentors, but also their parents are equipped enough to also support and complement the program so as we protect enough these girls. So
Hi, Adeline. Sorry, just to say we have to wrap up in 2 minutes. Thank you.
Yeah. Okay, thank you so much. I will be there. So next slide. So in terms of community as a whole, we are also implementing an evidence-based curriculum of SASA that implements the GBV prevention services. And in order to monitor and coordinate our program, we have developed an online-based data management system that helps us to collect data for and reporting for adolescent girls and young women. And each AGYW is having a unique identifier to track the services. Next slide. So to close, we collaborate with various stakeholders and in community and at the national level, including Rwanda Biomedical Center, MOH, local leaders, National Commission for Children, and others to make sure this program is well implemented in the community. Thank you.
Thank you so much. We only have 3 minutes left in our session, and I know there is only a 5-minute break before we have our next sessions beginning, and I want everyone to be able to continue their day. Thank you so much to Sylvia, Bernadette, and Adeline for your wonderful presentations. I just want to make a couple of closing remarks, and then I will hand it over to Lindsay. Some of the key points that were brought out across all 3 of these presentations is quite a bit about community service delivery, even that of clinical services. We looked at testing, we looked at prep, and so recognizing that we want to take services to where our adolescent girls and young women feel comfortable receiving them and are safe receiving them. I think all of these partners have shown how they have been able to adapt, not even just due to COVID, but as part of their innovation and programming. So as we continue to talk about some best practices and dreams, I'd really like us to think about what more we can do. Something in one of the presentations that was noted was we asked the AGYW. And again, we need to be communicating with our adolescent girls and young women to know what they want and how they feel most comfortable in service delivery. So thank you all for highlighting adolescent girl and young woman choice in all of these interventions. Something else that I wanted to highlight is talking about virtual adaptations. And we know that a lot of these were done in response to COVID, but we've also found that we've been able to reach some of our most vulnerable populations when providing this virtual option. And so we look forward to working with you to find out what is possible for virtual service delivery. So I want to thank everyone again for your presentations. Thank you as well, Lindsay and Kiernan, for the logistics support. And I will turn it over to Lindsay for a couple of final remarks.
Great, thank you so much, Annalise. And to all of our panelists, that was a great session. I think it was indicative of the really robust level of information that we ran out of time for Q&A. So as I mentioned, we will be working with the panelists to get responses to all of the questions, and we'll post that in the poster and program gallery in the on-air platform. When the session ends, there will be a Zoom poll that will pop up. So please give us your honest feedback on how you feel the session went. And thank you very, very much for your participation. We have a 5-minute break until the next session begins. Thank you.
Thank you, everyone.
Thank you.